Imagine a future where the fight against HIV is not defined by daily struggles, constant reminders, and relentless anxiety, but by a simple, twice-yearly medical routine, an injection that offers peace of mind for 6 months at a time. No more pill bottles rattling in backpacks or purses, no more daily alarms, and no more awkward conversations at the pharmacy counter. This might sound like the stuff of science fiction, but it is happening right now. Yet, as with so many medical breakthroughs, a critical question remains. Will this innovation transform the lives of millions, or will it become just another luxury for the privileged few? For almost half a century, scientists and public health experts have sought a silver bullet to end the HIV epidemic. The virus, first identified in the early 1980s, ignited a global health crisis, claiming the lives of millions and triggering waves of fear, discrimination, and activism. In those early years, the idea of prevention seemed almost impossible. Vaccines, the holy grail of infectious disease control, have proven elusive in the case of HIV, thanks to the virus's ability to mutate and hide from the immune system. But as the decades rolled on, the battle evolved. New tools emerged, and among the most promising was PrEP, pre-exposure prophylaxis, medications taken regularly to prevent infection. PrEP, in the form of daily pills or bi-monthly injections, has already changed the landscape of HIV prevention. Studies have repeatedly shown that PrEP can reduce the risk of acquiring HIV by more than 90% when taken correctly. In communities where PrEP is widely used, new HIV infection rates have plummeted. Yet the global numbers remain sobering. Every year, more than 30,000 people in the United States are newly infected with HIV. Worldwide, that figure stands at over 1,300,000 new cases annually. Despite the proven effectiveness of existing preventive tools, the gap between innovation and access remains wide and stubborn. Why does this gap persist? The answer is complex. Barriers to PrEP use range from societal stigma, lack of awareness, and logistical hurdles to the simple challenge of remembering to take a pill every single day. Only about 400,000 people in the United States are currently using some form of PrEP, a fraction of the estimated population that could benefit. Many people at the highest risk of HIV, such as young women, men who have sex with men, transgender individuals, and people of color, face additional barriers, from discrimination in healthcare settings to limited insurance coverage. The cost of medication, clinic visits, and associated lab tests can also prove insurmountable, especially for those without comprehensive health insurance or who live in regions with underfunded public health systems. Now, into this landscape of hope and frustration steps lenacapavir, marketed in the United States as Yeztugo. Developed by Gilead Sciences, one of the world's major pharmaceutical companies, lenacapavir is being hailed by researchers and advocates as a true game-changer in HIV prevention. Unlike previous PrEP regimens that require daily or monthly dosing, lenacapavir offers protection through just 2 injections per year, one every 6 months. That means a person could receive an injection in January and not have to think about HIV prevention again until July. The evidence supporting lenacapavir's effectiveness is stunning. In a pivotal clinical trial, known as the Purpose 1 study, more than 5,300 adolescent girls and young women in South Africa and Uganda participated. This population is among the most vulnerable to HIV globally, facing both biological risk and societal challenges, such as gender-based violence and limited autonomy. In the group that received twice-yearly lenacapavir injections, not one participant contracted HIV during the study period. By contrast, about 2% of those randomized to daily PrEP pills became infected. Another major trial, Purpose 2, focused on populations in the United States, South America, and Europe, including gay men, transgender women, and gender non-conforming individuals. Again, the results were extraordinary, almost total protection against HIV acquisition. Experts are almost unanimous in their praise. Mitchell Warren, executive director of AVAC, an international advocacy group focused on HIV prevention, described lenacapavir as the single best opportunity in more than 40 years of HIV prevention. Dr. Carlos Del Rio of Emory University notes that the twice-yearly schedule could help address 2 of the biggest barriers to PrEP, adherence and stigma, by making it easier for people to stay protected without constant reminders of their risk. Ian Haddock, who leads a Houston-based nonprofit serving Black LGBTQ+ communities, shared his experience. Now I forget that I'm on PrEP because I don't have to carry around a pill bottle. It really just expands the opportunity for prevention. Men, women, gay, straight. Just remembering a clinic visit every 6 months is a powerful tool versus constantly having to talk about condoms or making sure you're taking your pill every day. But as with so many medical miracles, the promise of lenacapavir is complicated by the realities of economics and politics. First, there is the daunting price tag. In the United States, Gilead has set the wholesale price at more than $28,000 per year, or over $14,000 per injection. While the company claims this is comparable to other brand-name PrEP options, for uninsured individuals or those with high deductible plans, the cost can be prohibitive. And even for those with coverage, the future is uncertain. The United States Supreme Court is reviewing whether insurers must cover PrEP, and Congress is debating significant cuts to Medicaid, the government program that provides health insurance to millions of low-income Americans. At the same time, key public health programs that once led the nation's HIV prevention efforts have been scaled back or dismantled, leaving dangerous gaps in outreach and education. The result is a landscape where the people most at risk of HIV may be the least likely to hear about, access, or afford the latest preventive tools. Dr. Suzanne Doblecki-Lewis of the University of Miami puts it bluntly. Lenacapavir could mitigate HIV-related racial disparities, provided it is made available easily and at low or no cost. Without that, we risk deepening the very inequities that drive the epidemic. Globally, the stakes are even higher. More than half of all new HIV infections occur in just a handful of countries in sub-Saharan Africa, where healthcare systems are chronically underfunded and the stigma surrounding HIV remains strong. Recognizing the need for broader access, Gilead has signed agreements with 6 generic drug manufacturers to produce lenacapavir at lower costs for 120 low- and middle-income countries, primarily in Africa, Southeast Asia, and the Caribbean. This is a positive step, but it leaves out much of Latin America and does not guarantee rapid or universal access. Negotiations over licensing, pricing, and distribution are ongoing, and advocates worry that progress could be slow. The potential for low-cost generics is enormous. UNAIDS, the Joint United Nations Program on HIV/AIDS, estimates that lenacapavir could eventually be produced for just $40 per person per year, dropping to $25 as manufacturing scales up. That is less than the price of a cup of coffee each month, a fraction of what is charged in wealthy countries. Dr. Andrew Hill, a leading researcher on global access to medicines, has called on governments to pursue compulsory licensing if voluntary deals with manufacturers do not deliver affordable prices quickly. If the voluntary licenses to generic manufacturers are not improved, then countries should explore compulsory licensing instead, Dr. Hill advises, pointing to past victories in making life-saving drugs for HIV and other diseases more affordable. Yet even if prices plummet and manufacturing ramps up, there remain logistical and cultural challenges. Lenacapavir is given as 2 injections under the skin of the abdomen, creating a small depot of medication that slowly dissolves into the body over 6 months. Patients must test negative for HIV before each dose, as the drug does not treat existing infection and does not protect against other sexually transmitted infections. Some people experience mild discomfort or pain at the injection site, and cooling packs are sometimes recommended to reduce swelling. And crucially, the long-acting nature of the drug means that if someone does contract HIV after missing a scheduled dose, there is a risk the virus could develop resistance, potentially undermining the effectiveness of not just lenacapavir but other drugs in the same class. The implications are profound. If lenacapavir reaches those who need it most, it could help tip the balance in the global fight against HIV, bringing the world closer to the goal of ending the epidemic by the year 2030. But if access is limited by cost, bureaucracy, or lack of political will, the breakthrough could become just another symbol of inequality, a miracle for some, an illusion for others. To understand what is at stake, consider 2 possible futures. In one, high-income countries rapidly adopt lenacapavir, offering it to anyone at risk of HIV through robust public health programs and generous insurance coverage. New HIV infections begin to fall, and public confidence in prevention is restored. Meanwhile, millions in lower-income regions wait years for affordable access, with preventable infections continuing to devastate communities. The gap between the global north and south widens, and the dream of ending the epidemic remains out of reach. In the other future, bold policy decisions and global cooperation pave the way for equitable distribution. Governments embrace tiered pricing, allowing low and middle-income countries to purchase lenacapavir at cost. International donors and aid organizations step up, funding outreach and education. Community groups mobilize to tackle stigma and misinformation, ensuring that everyone who could benefit from the drug knows about it and can access it without fear or shame. In this scenario, the HIV prevention gap narrows, and the world moves closer to a historic victory over the virus. The reality will likely fall somewhere in between, shaped by decisions made in the next few years. The approval of lenacapavir is not just a scientific milestone, it is a test of our collective values and priorities. Will we allow the market to determine who lives and who remains at risk, or will we rise to the challenge of making life-saving innovation truly universal? There are still wild cards to consider. If the United States Supreme Court rules that private insurers are not required to cover PrEP, millions of Americans could find themselves unable to afford even the most basic preventive care. Major cuts to Medicaid or public health funding could slow the rollout of lenacapavir in communities that need it most. Globally, supply chain disruptions, regulatory delays, and political instability could all threaten the promise of this breakthrough. And then there is the issue of drug resistance. As with antibiotics and other antivirals, improper use of lenacapavir could lead to the emergence of resistant strains of HIV. This is a particular concern if people miss scheduled doses or if the drug is used improperly. Public health officials and clinicians will need to monitor resistance patterns closely and adapt guidelines to ensure that lenacapavir remains effective for years to come. Yet despite the challenges, there are powerful reasons for optimism. The history of HIV is filled with examples of communities coming together to demand access, challenge stigma, and drive innovation. From the early days of ACT UP and the global AIDS activism movement to the rollout of affordable antiretroviral therapy in Africa, progress has often been made not just in the laboratory, but in the streets, the courts, and the halls of government. Real-world data from cities and states that have embraced PrEP show what is possible. In New York, San Francisco, and other urban centers, aggressive outreach and easy access to preventive medication have driven new HIV infections to historic lows. Conversely, in regions where PrEP use is low, often due to lack of awareness, resources, or political support, HIV rates continue to climb. These disparities highlight the urgent need for a comprehensive approach that goes beyond simply developing new drugs. So, what can be done to ensure that the promise of lenacapavir is realized for everyone, everywhere? Here are some actionable steps. First, governments and policymakers must commit to funding HIV prevention at all levels. This means not only paying for the medication itself, but also supporting the clinics, counselors, and outreach workers who connect people to care. Insurance mandates should be strengthened, not weakened, to guarantee that everyone at risk can access PrEP without cost barriers. Second, pharmaceutical companies must prioritize access over profit in the rollout of new treatments. Gilead's agreements with generic manufacturers are a step in the right direction, but the terms must be transparent, fair, and designed to reach as many people as possible, as quickly as possible. Drug pricing should reflect the realities of global need, not just the capacity of wealthy markets to pay. Third, communities must be empowered to lead the fight against HIV. This includes supporting grassroots organizations, investing in culturally competent education campaigns, and addressing the social determinants of health, such as poverty, discrimination, and lack of access to healthcare, that drive vulnerability to HIV infection. Fourth, ongoing research and surveillance are essential. The approval of lenacapavir is a major milestone, but it is not the end of the journey. Scientists are already exploring even longer-acting options, such as annual injections or implantable devices, and the search for an effective HIV vaccine continues. Real-world data on the uptake, adherence, and impact of lenacapavir will be crucial in guiding future strategies. Here is a secret that most people do not know. Experts estimate that lenacapavir could be manufactured for less than the price of a cup of coffee each month, if legal, regulatory, and logistical barriers are removed. That means the world already holds in its hands the tools needed to end new HIV infections. The challenge is no longer scientific, but economic, political, and moral. So, what do you think? Can we close the gap and bring this breakthrough to everyone who needs it, regardless of where they live or how much they earn? Share your thoughts and experiences in the comments below. Subscribe to our channel for more deep dives into the intersection of economics, technology, and global health. The future of HIV prevention, and perhaps the future of global health itself, may depend on the choices we make today. Let us keep this important conversation going, and together,